Robert. I'm one of the community clinical nurse specialists, so I visit patients at home in Camden, and that may include patients that live in a nursing home or in St Pancras Hospital. And I started my nursing career in the kind of palliative care setting, and I've sort of gone full circle.
My name's Louise. I'm one of the clinical nurse specialists working in University College London Hospital, seeing patients across the trust. We do out of hours work, getting calls from families in the community and from the hospital. I started in palliative care work, first of all working in HIV services at Chelsea and Westminster, and then moving to a hospice environment in South London, and then coming to work in University College London to have a more hospital palliative care experience.
It may not be that we're doing a lot of clinical things like taking bloods, taking temperatures and things, but we have more time to look at the sort of psychological and look at the holistic, what's actually going on with the patient.
I think it is the time factor. I think our big focus is looking at patients and families and really the meaning of what's happening with the illness. And I think just looking at how can we improve this experience and their quality of life at this point. So I think those aspects are what I enjoy about it.
I think it's very satisfying as well if we can, especially in the community, keep a patient, if they specifically said they'd like to stay at home, we can ensure that all the support and backup is there, and the symptom control drugs, and we can keep them at home and ensure they have good palliation and symptom control. Although palliative care traditionally is focused on cancer patients, we're now seeing patients with other diagnosis being referred, so we're seeing patients with chronic airways disease, heart disease, kidney problems, patients with neurological conditions such as MS and MND, and some of those we may meet quite early so that we can look at planning ahead for the future, so that they can make choices about what they do and don't want to happen.
Get referrals sometimes at the beginning of disease when someone's newly diagnosed, and will maybe be involved in the hospital and then refer back. There may be occasions we see people while they're having treatment for their disease, or sometimes we see patients at end of life, and often either to care and coordinate care in the hospital, or to get them home to where they would like to be. That may be at home, or that may be at one of our local hospices, or often patients at UCLH or from outside the London area. So we're liaising with palliative care teams all over the southeast. I think the whole hospital experience can be very just such a frightening experience at times for patients and families, and I think what's satisfying is that I sometimes think we aid good communication between lots of teams within the hospital, because a patient and their family are often being bombarded by so many different teams, and that actually we often work alongside those teams as sort of a liaison, or bridging that communication gap that sometimes exists.
Patients often get quite frightened when they're referred to palliative care because they associate palliative with, oh my God, I'm going to die, it's the end. But actually, quite a lot of the work we do is with patients maybe quite early on in their disease, their illness, and supporting them through treatments. And it may be that if it comes to a period when things become more stable and the symptoms are well controlled, we may actually discharge the patient, and then they can always be referred back, or the patients are happy they can contact us back in the future as things change. So patients kind of come in and out of our service as well. I often find patients and relatives may be quite anxious for the first time they meet us. They're not sure what to expect, who's going to come in the door, and are we going to start immediately launching in stories about the end and death and dying. But actually, and once they see that we're hopefully a friendly, approachable face, they feel reassured that there's a whole range of things that we can help with, not just end-of-life care.